Well, good evening, everyone, and welcome to the webinar that we have arranged to discuss and explain aspects of the guidance which was published by the Faculty of General Dental Practice UK and the College of General Dentistry. So I'd like to offer a wide welcome to you all. This has been a very difficult time for everyone, and certainly within the dental profession, we've faced a number of challenges over the last few weeks and months. There's been considerable uncertainty about our future, and although that might be becoming slightly clearer at the moment, uh, we still desperately looking for guidance, support, and leadership. Um, One of the positives that certainly to come out of COVID-19 when we're desperately searching for some is the level of cooperation and collaboration that there's been across many sectors within healthcare and particularly within dentistry. And one example of this is undoubtedly the group which we convened to look at guidance, in particular around general dental practice. It was a disparate group from a variety of backgrounds, but I must say heartfelt thank you to all of those involved. The work they put in was absolutely incredible, and the guidance document that we've produced is a testament to that, where they were able to do that over an incredibly short period of time. I'm delighted that a number of the task group members are with us this evening. The key aim in producing this document is to support the general dental practice team to get back to practice, but to do that in a safe way. And that's safe for our patients, safe for our staff, and safe for the wider community. And that has to be borne in mind at the present time when we're sitting still at alert level 4. Again, I think I just picked up briefly that we're well over 300 deaths have been reported again today. So there's absolutely no way that we can consider going back to general practice in the way that we did previously, and we certainly can't be thinking about doing that within the next few weeks. So the guidance has been extremely well received across the dental profession, but clearly there have been a number of questions that have been raised. And we thought the best way of addressing that was to have a webinar such as this, to produce simplified advice sheets, which are already underway and will be distributed fairly soon, and also to create a resource. And that is going to be held on the College of General Dentistry website. And that will hopefully be a portal for you to ask questions and for colleagues to answer. But also there'll be an alert mechanism so that any updates within the guidance, and there are likely to be several over the coming weeks and months, if you register there, you will get an alert to any particular updates. So this webinar is going to last about an hour. It's being streamed live on Facebook and YouTube. And which I think is absolutely fantastic, the level of interest that we've had here. It's not going to be possible to answer all the questions that have been put forward, but we're going to try. The panel was convened from our task group, as I say, and I'm absolutely delighted to introduce to you this evening Onkar Denoya, who's a general dentist and who was chair of the task group. Mick Horton, who many of you know is a past dean of the faculty, but he's a trustee of the College of General Dentistry, another GDP. Roshni Karia, who is our vice dean at the faculty and also GDP. We're delighted that Diane Rochford is here with us, who is president-elect of the British Society for Dental Hygiene Therapy, but she's here in the capacity representing all dental care professionals through her association with BAPD. Chet Trivedi, who is a consultant in emergency medicine, but before that was maxillofacial surgeon, and before that was a dentist. So I'm delighted to introduce the panel to you. And I would also just finally like to thank Sensodyne, who have arranged the webinar this evening and are also involved with helping us develop the summary sheets, which will be distributed shortly. So anyway, welcome. So before we kick into the questions that have been sent in by you, I think it'd be worthwhile me just asking a couple of my colleagues and panelists So about the guidance and how it was developed. And I'll maybe go to Chet first and say, could you explain, what was different about the guidance that was published on Monday, and particularly the approach that we took and why? Chet, have we?
Yeah.
Great. Chet, I don't know if we can hear you at the moment. I can't.
Can you hear me now?
We can. Brilliant.
Right. So I think the first thing we're going to realize is that dentistry across the UK is a very varied situation. What happens maybe in the north of England or maybe in the south, people have got different ways and different styles of practice, like NHS, private, different specialities. And one of the things we've got to look at also is that COVID is affecting different parts of the country. Now, one of the challenges of developing guidance is if you've got a one size fits all for everybody, there could be issues around something that may work for one practice, may not work in another practice. So I think our challenge was to actually develop guidance that dentists and dental professionals could use as a framework to actually adapt guidance on what works for them. And the main way to do it is actually develop a risk-based approach where people can look at their personal risks in terms of their health, the risks, the type of work they're carrying out, their environment that they're working in, and also the alert levels. So we wanted to actually develop a framework which would actually allow dental professionals to adjust their work according to their risks. And I think Mick's going to tell us more about the risk matrices that we developed.
Yeah, Mick, so one of the challenges I think when we convened this group was that FGDP and CG Dent are UK-wide organisations, which is fantastic in itself, but it is a challenge when perhaps the four nations take a slightly different approach or a nuanced approach to the provision of dental services. So I guess one of the questions that has been asked, is this applicable to all four nations?
Well, yes, absolutely. As you say, both organisations, the FGDP and CG Dent, are both UK-wide organisations. And the guidance itself, because it's a risk-based approach, can be used anywhere within the UK. But what we need to be aware of is that we may have contractual obligations or legal obligations within those individual nations. And we must follow those contractual or legal obligations ourselves, but we can apply the risk-based approach to practice in any of those nations. It's not a blanket approach, and as Chet said, it isn't one size fits all. We can actually modify it to our practice, our team that we work within, and within for our patients, looking at the risk assessments of all those different sections, bringing them all together so that we can actually get something that is tailor-made for ourselves. As alert levels change, then we may find that the scope of practice itself changes, and the application of this guidance through risk assessments should allow the profession to tailor-make what goes on in the future, not just now, and that's the beauty of this. Would you like me to talk a little bit about the matrices?
Yes, yeah, that'd be great, mate. Yeah.
For those people that have looked at the documents itself, you'll see on the actual matrix, there is a patient journey that's spread throughout the whole document. And we looked at each item within the patient journey and looked at those specific areas related to that part of the journey. We then looked at how risk would impact on that area in the journey and the severity that having a risk would create within the area. We also looked at how often or the chances of that occurring. So with that, you should be able to work out what impact is there, the chances of it happening, and how often it may happen. We then look at how you would mitigate against those risks. So on the right-hand side of those matrices, you'll see there's a whole column which are areas of mitigation that you could actually apply within your practice in order to lessen the chances of that risk occurring. We've applied the ABC approach, which was an FGDP approach within their own standards. A for aspirational, B for basic, and C for conditional. And that follows the same as the other guidance that's out within the FGDP. And you should see that if you follow the basic principles of those, that will allow some basic mitigation. There are aspirational mitigations that you can also apply. And then underneath that, we also look at the different alert levels which are nationally given. So we can actually look at any specific mitigations that may be applicable to the alert levels nationally as well. There is also above that some narrative which will actually give a bit more explanation to how those matrices have been developed.
Thanks, Mick. I'm sure that was a help to many people. There is a challenge between actually having guidance that is robust, rigorous, and demonstrates the methodology, with one that is accessible, readable. And I appreciate there are 68 pages to it, and some people probably wanted something a lot thinner and a lot more accessible, which I hope we'll be able to deliver on. But there are others who probably wanted even more detail. So anyway, so the questions that have been asked, many have come in already ahead of the webinar, and some that I see are coming in through the Q&A at the moment. So one that is, I guess, very topical on the back of an announcement from PHE yesterday was, in line with the recent PHE review on COVID risk amongst BAME, should BAME or staff at a high or moderate risk of COVID-19 be provided with enhanced PPE for low-risk AGEs? So it's, I guess what we're looking at is perhaps why is the risk, and should there be any differences in terms of the PPE that is utilised? So I think Chet has got a particular interest in this, and I know he has published papers on this, or has had one accepted very recently to be published. So Chet, can I ask you to take that one?
Sure. I think the first thing before I answer this question is we've got to look at that. We've only been working with COVID over the last 4 months. So I think as every day there's new information, and every day we have to adapt to the new guidance that comes out. Now, especially when we talk about BAME, there's been data that's now supported by the government, the National Office of Statistics, that says that people from BAME backgrounds are at higher risk of death from COVID. So the first thing is that the data now was obviously from the review yesterday, but the question is, what impact does that have on the dental profession? I think the worry for the dental profession is that because we work in such close proximity to the patient, that there's a possibility of a higher risk, but at the moment there's no studies on this. So I think the sensible thing is, the first thing is to see what the risk assessment is for that person. So rather than to put all BAME, everybody in the same category, we've got to look at what the risks are. So things like age, sex, other comorbidities like diabetes, blood pressure, which are more common in BAME communities. So everyone's going to have an individual risk. Then I think we sort of talking about AGE, so the aerosol generated exposure, we've also got to consider the actual procedure that you're doing. So is it like a smoothing down a cusp that might take 2 minutes, or is it going to be like a couple of crown preps? So I think we've got to do a risk assessment and then decide what is the most appropriate level of PPE. My opinion is that if you've got a higher risk, then you need to protect yourself and also protect your patient. So I think the word here is provided. I think obviously there's a lot of concerns about access to PPE, but we should all be striving to actually make sure that our dental team is protected and our patients are protected as far as possible, whilst being practical.
Thanks, Chet. And Ankur, did you want to come in on this?
Yeah, just to add to that, I mean, there are sort of guidelines on this, and there are sort of risk assessment tools available which will help practices manage sort of carrying out risk assessments for their staff and guidance on what to do with that.
Thanks, Onkar. And I think it's just worth making the point that, you know, in other aspects of healthcare, it might be possible to redeploy staff. That can be more difficult as a dentist, perhaps, or a hygiene therapist, or as a dental nurse. It might be more difficult to redeploy, and maybe a desire to continue working. But as Chet and Onkar have said, it's about assessing that risk and then mitigating against that accordingly. So it's not different levels of PPE for different people necessarily. It's just assessing that risk and taking the appropriate risk. Irrespective of background, you may well do the same. If you're diabetic, you're an older male like me. Anyway, let's move on to next question, which is, during the current alert level 4, can you please confirm what level of treatments we are currently able to undertake? So Onkar, I think you're the man with the mic at the moment.
Yes, sure. Thanks, Ian. Well, basically, as you pointed out earlier, Ian, I mean, we're not in a safe environment at the moment. You know, the current alert level is 4, and that's defined as the level at which the NHS is stretched but can cope. So there's still a lot of virus circulating in the community, and I think really what we need to do is follow the guidance, I think, which is the same from all the CDOs from all 4 nations, which currently is that we shouldn't really be providing routine treatment for our patients. And for any patients that require treatment, then I think what we need to do is, you know, use our guidance and do a full risk assessment. And that will enable us to have the appropriate protocols and appropriate PPE to be able to deliver the care safely. So, you know, that's what I think can be provided at this level, really.
Yeah, thanks, Onkar. And I know this has been a bit of an issue down in England recently since the announcement last Thursday. And despite the accent, I'm based in the southwest of England, and there was an announcement last Thursday that practices were being opened. And I know that we have all had, in practices, we've all been inundated with phone calls from patients expecting us to be open as normal. And I think it's, you know, it comes back to managing expectations, not just within the profession, but you know, with the wider community, within our patients. And I know quite a bit has been done with that through NHS England, getting information out in the press and with local dental committees. So it is important that as a community of dentists, dental professionals, we get that message out there. It's not business as usual and won't be for some time yet. So, so talking about dental professionals and hygienists and nurses, I think it's time we brought Diane in to give some of her expert opinion. So, as a hygienist, the document suggests standard surgical masks and eye protection for low-risk AGEs, e.g. hand scaling and high volume suction is deemed appropriate. So with hand scaling and high volume suction deemed appropriate. So given our proximity to the working with the patient, is this appropriate if patients were to cough or sneeze? So if you're doing low-risk AGEs, can we just wear a mask and visor as previous?
Okay, so thank you, Ian. So, so obviously the guidance is looking at that is seen as a basic requirement to be using, just to have a surgical mask and a visor. And obviously with something like this, we need to assess the patient. If they have a cough or they're more likely to sneeze, maybe if it's at this time of year and they're suffering from hay fever. So, you know, if they're more likely to have that kind of, you're more likely to be exposed to the aerosols, then maybe we need to then again assess the situation and use appropriate PPE. So if we need to use more advanced PPE, then that may be necessary as well in that case. But depending again on the situation, if it's oral hygiene instruction, is it hand scaling, you know, the type of appointment that we're doing as well.
Thanks, Dan. I think that's an important point and a sort of nuanced difference in that we were trying to get across in our guidance, that there are other factors beyond just AGP and non-AGP that must be taken into consideration.
Yeah.
And I'm sure we'll touch on that as the webinar goes on. So I'm going to, I think, are we going to keep you in the hot seat here, or are we get? No, I don't think. I think
I've got a break.
I think we're going to go off for that one.
A break for 2 questions.
So another topic that has that's certainly been given quite a lot of airtime recently is around testing, and clearly some countries seem to have done this very effectively, testing, tracing, and tracking, and there has been a great desire from the government to get testing up as quickly as possible, and many people interested in, can this be applied across to general dental practice? Could it help us identify the patients that perhaps are carriers, asymptomatic carriers? Could this help with us in practice and safeguard our staff and our patients? So I'm going to throw that one over to Chet, who would seem the obvious individual to answer a medical question on that. So Chet, what is the role of routine COVID-19 antigen testing in dental practice?
I think, Ian, that if we went back to the ABC, this would be aspirational. This is what we should be aiming for. But I think routine antigen testing is a challenge. So I'm actually running a clinical trial testing salivary antibodies for COVID and compare that to blood. So things are moving, but I think some of the things that we have to look at is the challenges. So currently, if you go to a hospital, you take a swab taken and it'll be reported in a standardized microbiology laboratory. And if you're really lucky, you might get the result within 3 hours. So there are now kind of small portable PCR machines, but the issue is they're very expensive. They take about 2 hours to turn around, and the accuracy depends on how you sample. So I'm not sure if anybody in the audience has had a nasal swab done, but it's incredibly painful because you've got to get your swab all the way to the nasopharynx. At the moment, the best accuracy from nasopharyngeal swabs is about 70%, and if you do oropharyngeal swabs, it's about 60 to 65%. Then you have the small issue of accuracy, who's going to do the Q&A, who's going to do the patient follow-up. So I think these are the kind of things that we need to build into dental practice. And the second thing is the cost. I couldn't tell you exactly how much a portable swab would cost, but we'd have to find ways to work with the government to establish this. But I think the bottom line is the equipment is nearly there. It's just the Q&A and actually how it's used outside the big hospital setting where you've got 10 technicians doing this, and how would actually train the dental staff to make sure that swabs are taken accurately, swabs are taken safely, because if you're going to be taking a swab, you'd have to make sure you've got good PPE on because you're at a higher risk because you're actually dealing directly with nasopharyngeal aspirate. So I think the bottom answer is we should be looking towards it, but we've just got a few challenges to overcome before we get there. But maybe in a couple of months, we may have a better idea of implementing this in dental practice.
Thanks, Chet. So that's something that we're not going to look forward to next week. That's something a bit in the future. But perhaps this is one for Diane that is possibly going to happen next week. So can polishing of teeth be carried out following periodontal treatment?
Okay, so well, I've been asked. Sorry.
I've got a supplementary question. What level of PPE is required as well?
So, well, I've been asked this question so many times in the past few days from all angles. So with regards to polishing, obviously at the moment, because the risk level, the alert level is high, we're still in phase 4, then obviously we're trying to encourage the team not to be doing aerosol generating procedures. And so if we can minimize polishing, then that would be better. And also, I think it's also, and then as the alert level comes down, then we can start to introduce that. But I think from our point of view as hygienists and therapists, and a patient expectation as well, the patients expect that if they're coming, they're going to have their hygiene appointments, polishing, that kind of thing. And I think before, when we're maybe triaging or, talking to the patients, explaining and dealing with their expectations as well, and explaining that we're not in a position at the moment because of the risk levels or the alert levels to actually to be doing some polishing at this time. But as we reduce, then we can start to introduce that.
Okay, thanks, Diane. And I'm sorry to pick on you this
and
evening, but the hygiene therapy community is quite rightly got a number of concerns about not just the treatment that is going to be available or able to be done, but also their exposure, as I think we're all aware of the data that was released a few weeks ago. So another question is, when are dental hygienists permitted to carry out high-risk aerosol exposure, such as use of an ultrasonic scaler?
So I think, again, the guidance is showing, and the guidance showed in there is to wait until, in a similar way to what we've done before, wait till the alert level comes down, and we're in a much safer position to be able to do that as well. And we've got all the correct PPE in order. Okay. So we've got more advanced PPE.
And I think I'm right in saying that a common usage of the 3-in-1 is to blow around the neck of the tooth.
And again, just keep that.
I am a dentist. But, so what are your thoughts on the 3-in-1?
Yeah, again, just keep it like, ideally we'd say no 3-in-1, ideally, and if we have to, keep it minimal, but keep it with high volume suction as well. So, but try and keep it to a minimum. We just want to keep the levels down. And we still have, as dental hygienists and dental therapists, we still have a role to play. And I think there is a concern around that as well, in that there's a lot of people thinking that there's no role for them to play, but there is. And, we've got lots of oral hygiene instructions to be given, which is all low risk, low AGE, so we can be doing those kind of things and working with our patients and on their oral hygiene, as well as our normal procedures that we would be doing as well. So we've still got a part to play, and very, very much so.
Yeah. No, and I'm aware that that's certainly the feeling amongst the CDOs, and Roshni has made the point on several occasions at meetings I've been at, that we do, as dentists, sometimes we overly focus on the drill and having a drill in our hand. There are many other aspects of dentistry, particularly minimally invasive dentistry, that we can do a huge amount for our patients in terms of maintaining their oral health or improving their oral health. So, and
I think we've, like, kind of a lot of the webinars that we've been on over the past few weeks, there's much more emphasis on oral health, improving their oral health, because obviously it's going to offset with COVID and that susceptibility as well. So we've definitely got a part to play. Yeah.
No, absolutely. So, and although I've just said we tend to focus a bit on aerosol generation, I guess that is one of our concerns as dentists. I guess, is having had so many patients with irreversible pulpitis over the last 8 or 9 weeks, where we haven't been able to pick up a high speed, open the tooth, and relieve their pain. But so I mentioned Roshni earlier, and I've let her off the hook so far this evening, which is not like me. So Roshni, prime yourself. So this is around intraoral radiography and photography, and that was included within our matrix. And I wonder, should that be classed as a high risk procedure if someone's got a cough risk or a cough, or a gag reflex? What are your thoughts around taking radiographs and intraoral photographs?
Okay, thank you for the question, and welcome everybody. I think that's a very good question, and we suggest in our guidance that if a patient is likely to be intolerant or has a gag reflex, then we would consider that as a high risk. But at the same time, I think it's important, just like pre-COVID, to weigh up the risk versus benefit of taking a radiograph. Are you justifying that radiograph, and the appropriate mitigation measures in place? I think taking, as we've discussed already, that all into consideration with an appropriate risk assessment, including the national alert level in place, should hopefully answer that question about the PPE that you need to use.
Thanks, Roshni. So there's a number of other questions come in today about vulnerability, and I think that's probably one we'll ask Chet to come in on again. And it's really about what is the impact of dental related work on those who may be more vulnerable to a COVID-19 infection. So this is about vulnerability of infection, not increased risk of morbidity or mortality.
I think given yesterday's announcement of especially BAME people being high risk, I think we've got to make sure that we just don't focus on BAME, because there'll be lots of non-BAME people with diabetes, blood pressure, having treatment for cancer. And I think I've got great empathy for people in that position, because I myself at the moment am shielding because I'm a diabetic, I've had a stroke, I've got high blood pressure, and there's a lot of uncertainty about what I can and can't do. So I think I totally appreciate the concerns, but I think the key thing is that at the moment, it's about risk assessment. Two diabetics will not have the same control. You might find that some people have got very good blood pressure, some people don't. So I think the first thing to do is actually do a risk assessment. So there are some risk assessment tools that are already available. The NHS has some, but these were primarily designed for doctors and frontline health staff in the NHS. As you may be aware, 246 healthcare workers, including doctors, nurses, and social care staff have died from COVID since March. So I think that the first thing is to actually do a risk assessment to see where you fit. Now, the risk assessment should be done by a medical practitioner or an occupational health specialist that knows your medical records. Now, on the basis of that, they'll probably give you the advice of how risky it is for you to continue with what you're doing. And this may vary between individuals in different practices, depends on what kind of work you do, what the alert levels are, what your personal kind of medical risks are, your ethnicity, and even things like age. If you're an elder male, the risks are slightly higher. If you're pregnant, the risks are higher. So I think the first thing to do for everyone, not just if you're obeying, but for everyone to do a risk assessment in their practice, and depending upon what triggers, actually speak to your family practitioner, or if you're under a hospital specialist, to speak to them and then act accordingly. I think it'd be outside the scope of this guidance, to speak about specific outcomes for specific conditions, because every week you'll have some conditions taken off and maybe new conditions put on. So I think you've got to keep a close eye on what PHE are saying in terms of the vulnerable patients, the patients that are shielding, and how you fit into that. So I think a personalized risk assessment that's conducted in conjunction with a medical professional that knows your medical history is the safest approach.
Thanks, Chet. And I guess, all the way through this webinar, we'll be talking about risk assessment, risk-based decision-making, and that is absolutely key. And part of the reason around that is clearly because of the paucity of evidence that we have around COVID and the challenges with translating existing evidence across. And while we have such widespread concerns about the safety of our patients and also the wider population, we have to set the risk threshold that bit higher. But coming back to evidence, I'll just do a quick plug that there's a huge amount of research going on in the UK at the moment. We've really accelerated the sort of pace of getting research done within dental care, particularly within primary dental care. And Professor Gail Douglas at Leeds is doing an online survey which is looking at the pandemic, the impact in the pandemic of dentists in primary care. And I would just urge you all to have a look at the Leeds website and perhaps participate in the online survey. And I'm sure many of our members of both CG Dent and FGDP, we will be encouraging you when there are opportunities to engage with research and to actually be part of this research agenda and drive things forward. So we're making more of an evidence-based decision rather than perhaps an experience or an eminence-based decision, as sadly we are having to at the moment. So that was the brief commercial break to promote research on behalf of Leeds. There are other universities and research centres available. So if we move quickly on, another question that's come in is one that I'm just going to love giving to Mick, and I'm sure this is one that plenty of people have been asking about. It's about fallow period. There's many new words I've picked up over the last 3 or 4 months, and certainly fallow is one of them. So guidance suggests that mitigation factors can be considered when looking at the fallow period between patients. Mick, can you explain how we implement this in a risk-based manner?
Yes, I mean, I'm sure everybody's sat on the edge of their seat at this very moment. There's very little evidence as to the clearance time of those airborne viruses within dental practices. So it's very difficult to put absolute figures on these. And currently the PHE's guidance is that we must allow a 60-minute time before decontamination of the surgeries. If you link back to what occurs in an operating theatre within a hospital operating theatre has negative pressure. And in those areas, they actually allow a 20-minute fallow time. A dental surgery is a neutral, in most cases, a neutral airspace rather than negative pressure. And as I said before, the PHE have recommended a 60-minute fallow time, but you can look at mitigations. The mitigations that you could look at are the type of procedure that you're carrying out, the length of the procedure. If you're stoning a tooth for 2 seconds, that clearly generates far less aerosol than if you were going to do a lengthy 30-minute restoration, for example. You can look at the use of rubber dam, the use of high volume aspiration. The size of the room that you're actually in will also affect it, and the ventilation within that room, which allows for the air exchanges. So we need to consider quite a lot of different factors. There isn't anything that says, if you do this, then you can reduce it by this amount, or if you do this, you can have no time whatsoever. I think you must have a fallow period. We must follow some of the PHE guidance, but we must understand that there are mitigating factors in terms of how we carry out that treatment. I think one of the other things that is often missed when we look at this approach is the reason we have the fallow time to allow that to dissipate is not just for decontamination, it's also for the next patient that's actually coming in the room. So you may want to take account of who's actually going to be in the chair next, what sort of thing, is it a high risk patient? And if they are, you may want to consider how you zone your appointment books. You may want those lengthy aerosol generating procedures or the high exposures at the end of a session, just to allow that time for everything to settle down. We've talked about starting the clock on that exposure time or the fallow time from also the end of the procedure rather than when the patient walks out of the door, because clearly some procedures we're not constantly generating those aerosols. The aerosols are only generated whilst we're carrying out the procedure, but sometimes we may sit there for a little while longer doing other non-aerosol generating procedures. So I think there's a lot of factors. There's no hard and fast, this is how long it would be under these circumstances, this is how long it would be under these. People have different ways of ventilating the rooms. I think it becomes more difficult the more difficult the ventilation is and the air exchanges within the room as well. So I'm sorry I can't give a hard, fast rule, but hopefully it gives you some idea of how you can assess.
Thanks, Mick. And I know there have been a number of questions have been coming in on the Q&A session as well, as how can we justify 60 minutes, stating it's 60 minutes? You know, why can't it be something shorter than that? These were all questions that were kicked around within the task group. We had long discussions about what evidence there is available and what it suggests, and it's anything from 15 minutes to 2 hours. In the end, our decision was based on the advice of Public Health England. They get their advice from NervTag and SAGE, and it's very difficult for us to put forward an argument against that at the present time. That's not to say we haven't tried, but we are recommending the guidance set down by Public Health England. The good news, I guess, is that there is a considerable amount of research going on at the present time, because the length of the fallow period has a massive impact on practices. It's a massive impact on access to patient care. And if that isn't an issue that is addressed quickly, it's going to translate into problems for many, many patients and problems with their ongoing oral health. So the 4 CDOs, I'm sure, absolutely get that. The public health consultants absolutely get that, and practice get that. And that is a real problem for us in general dental practice at the moment. While the levels are high, I guess, as Mick has said, we try and take a sort of practical approach to it. To try and do as few aerosol generating procedures as possible. When we do them, perhaps look at putting them at the end of sessions if we can. And hopefully there will be some additional advice coming out as soon as possible to let us reduce that to an acceptable level. Many questions around air exchange, air ventilation, and which I guess it's very difficult actually to give a definitive answer on that. And there are experts that will come in and be able to give you advice on the air exchange that you are managing to obtain with the different devices you can buy. And I guess that would be our answer. We would get expert advice about whether you comply with that or not, because that will be part of your risk assessment, and you will need to justify if you're operating with a 15-minute fallow period rather than a 60-minute. And if you can, fantastic. So, sorry, moving swiftly along. Again, Mick, well, you seem to be the man in the chair at the moment. So, high-risk aerosol-generated exposures cannot be undertaken in a windowless room, it states. So, can we use air conditioning during dental treatment?
I think what we actually stated in the document was, it wasn't that you cannot do any, it was you can't or you should not carry out any where there is no mechanical ventilation. Because if you have a windowless room with no mechanical ventilation whatsoever, then clearly everything is just going to float around within that room and never get cleared, or just take forever to be cleared. If you do have some mechanical ventilation, especially something like air conditioning, then you need to consider what you're doing with that air. If the air is venting outside and you're actually removing the air and extracting it to the outside world, then clearly that will allow for that air exchange that Ian has just been talking about. If it's just recirculating the air within the room, then that doesn't allow for the air exchange. You're not actually exchanging that air for anything else. You're just recirculating what you've already got there. So you really need to take some advice if you're going to start using something with an enclosed room with no air exchange. And think very hard about, are you actually putting yourself and others at risk?
Okay, thanks.
I believe Onka wanted to say something as well.
Sorry, Onka.
No, it's okay. I think you covered the point, Ian. That's fine.
Yeah, thanks. So actually, we're just going to go slightly off piste a bit, because we've had a number of questions regarding hygiene support or hygiene therapy support, and around, we mentioned four-handed dentistry on a number of occasions as a way that you can work more efficiently, more effectively, and potentially reduce aerosols. The use of high volume suction. And I guess, Diane, this is the one that you'll be delighted I'm going to lob to you. So what's your view on hygienists having support, nursing support when they're working?
So, well, I think, both society, BSDHT and BADT, we both think that nursing support is essential, definitely gold standard, and it's something that we will continue to push for. And we always recommend to our members to make sure that they, that they can have nursing support in some way. We have a risk assessment that we've done for members if they need it, so that they can assess the situations, because we're very much aware that some practices do have nursing support, some don't, and so are different levels of nursing support as well. And so I think it's probably more so, and going through the guidance and all the reading that we've been doing, one thing is for sure that I think hygienists and dental therapists definitely need more nursing support going forward with this whole situation, definitely.
Diane, just to put you on the spot,
Yeah.
there has been a lot, again, there's been a lot of concern clearly from our dental nursing colleagues
Yes.
about a return to work. And I understand
Yes.
there's been quite a lot of fear and anxiety and the risks involved. And I think we're going to ask Onkar in a minute or two just to talk about specific groups around vulnerable groups. But I mean, what are your thoughts or any sort of reassuring words that you might be able to give the wider dental care professionals, particularly nurses, coming back to work?
Again, so just making sure that they have everything in place, you know, that they feel, you know, that they feel confident, that they feel safe going back to work as well, you know, and primarily, you know, people's health is at risk, the patients, their health, their family's health. So we're always recommending, you know, follow the guidance, make sure that things are in place. And you know, we've had a lot of questions, and I'm sure the nursing, you know, from the dental nursing point of view about safety going back. Is it safe for us to go back? And sometimes it just needs a conversation and explain to your, you know, to your principals and to the practice owners, you know, the concerns that they have, and then maybe hopefully that, you know, they can work through those concerns that they have, just to make sure that they do feel safe and they've got the appropriate PPE. Obviously, PPE is going to be a contentious issue for a while because it's, you know, availability, but just making sure that they have, you know, that they do feel safe and having those conversations and working as a team. I think teamwork is so important, and being flexible with the teams as well. So yeah.
Yeah, great. Thanks, Diane. And I'll just I'll do another quick advert. I don't know if many of you watched the webinar last night that was hosted by the dental deans. It was on health and well-being, and I would say that will be available through any of the Royal College websites. It's really worthwhile watching and directing. There was some fantastic advice. Janine Brooks, Jimmy Boyle, you know, gave all the panelists gave some really wise counsel about what we should be looking out for and how we can support our colleagues. And this is going to be it's been a difficult time the last few weeks. I think the transition going back to normal, when we eventually get there, if we do, is going to be even more stressful. So that is worthwhile just watching out. Diane, I think that's excellent. You highlighted that.
Yeah, just lots of support. Lots of support. Yeah.
So, Onkar, we mentioned briefly about you know, vulnerability in certain groups. I was just wondered that you know, if you could maybe say a little bit more on guidance, particularly around patients in vulnerable groups, and should they be treated in general practice? And if they shouldn't, what should we do with these patients?
Sure. Well, thank you, Ian. Well, basically, again, I'll use the buzzwords. Risk assessment is the key. I mean, we've been using that so often over the last 2 or 3 weeks. So yes, I mean, that is the key. I mean, first of all, with these extremely vulnerable patients, the first question we need to ask ourselves is, you know, what is the risk to them for having that treatment at the moment? You know, in the alert level that we're at the moment. So we need to really assess whether that treatment is absolutely necessary now, or whether that can be delayed. I know there is guidance in Wales where, you know, vulnerable patients are, practices are told that they need to be referred. But as the threat levels reduces, I think, you know, we are the best people to treat our patients. They know us and we know them really well. So I think general practice is definitely the place to treat these patients as the stress level comes down. But again, careful assessment, careful risk assessment to ensure that we've got the right precautions in place and the right procedures in place to be able to treat them safely.
Thanks, Onkar.
That was the question?
Yeah, that was it. Yeah, brilliant. So I've got a question here on the management of medical emergencies, and I was wondering if any of the panel would be interested in answering that one. Chet?
Yes. Hi, guys. So my other hat I wear normally is an emergency medicine consultant, and I think medical emergencies is thankfully a very rare occasion in the dental world. But I think there's a couple of little things I think you just need to think about. First of all is in cardiac arrest. So the UK Research Council provided some guidance on kind of pre-hospital cardiac arrest. And I think the bottom line is that you do not go near the mouth. You don't do an airway assessment. You don't check for breathing. You go, basically, you cover the mouth with a cloth. Obviously, you have to confirm that they are in cardiac arrest. So if they pull them, you know, a cloth off their mouth, then that means they're not. But if there's no signs of life, then basically you focus on high quality chest compressions as you normally would, and it's safe to use the defib, but you don't do any airway procedures. Now, initially, there was a bit of confusion between PHE and the Research Council of UK on whether chest compressions count as AGP. The latest solution is yes, it does, because when you're doing compressions, you can actually force air and secretion, and sometimes people even have vomit and other secretions coming out of the mouth. So the plan is to try to wear simple PPE. So you're not going to delay by getting into your FP2s, FP3s, but if you're doing simple compressions, if you put on gloves, a simple surgical face mask, and if you have a visor, then it's safe for you to do your chest compressions. But I think if all of you who've done BLS before would have been told, think of your safety first. So I think that's the key. The two things that are not mentioned is actually choking. So if anybody's actually seen a patient choking, you'll see that they produce large volumes of aerosol and droplets and everything else. So I think you should try to not let them choke, that's for sure, but try to maybe wear the best PPE that you can get your hands on. So again, not delaying treatment, because for choking, you haven't got that long to remove the foreign body. So even wearing simple PPE and a visor and standing behind the patient, so you're not in the line of their kind of projectile cough. And the second one is actually patients with asthma and COPD, where they may have a persistent cough. Again, be sensible and think of AGP, but it doesn't mean we don't treat these patients, but you just might want to have kind of your simple PPEs in accessible areas. And one of the things we suggested was actually having some simple face masks and gloves and a visor in your medical emergency kit. So there isn't a huge amount of difference apart from any emergency that's going to be related to the airway or breathing, which is choking, COPD, asthma, and in cardiac arrest. Carry on with your good quality CPR, use your defib, but try to wear some simple basic PPE if you can.
Brilliant. Thanks, Chet. There's a few quick fire questions just before we go on to the next one. Did Onker say yes to routine dentistry or no? I didn't catch it.
At the moment, the advice is no.
Okay, great. If we can't do routine work and your guidance says we can't do high-risk AGEs at level 4, what can we do? Well, I think the answer to that is it's discourage AGEs at the current time. So yes, there are going to be situations where you have to pick up a high-speed drill and open a tooth, and that's perfectly acceptable, but you have to do it with the appropriate PPE. So I think that hopefully that will answer the question. So it's again avoiding high-risk AGEs whenever possible. We've had quite a few questions that have come in around oral mouth rinse. And I know that was a topic that was discussed last night at the webinar at the RSM. And I can think of no better person to answer this particular question. Mick, so we haven't recommended the use of preoperative mouth rinses. Others have. Why not?
Well, I mean, this was quite a lengthy discussion that we all had. We looked at all the evidence that we could that was out there, and there was insufficient evidence to show that it does reduce the virus sufficiently to justify its blanket use. The point is that the virus actually doesn't live in the mouth. The virus lives in the nasopharynx and in the lungs. And whilst there may be virus within the saliva and within the mouth that's detectable, if you clear that virus by using a mouthwash, the very act of breathing will repopulate the virus back into the saliva and into the mouth. So there is insufficient evidence to show that there will be a large effect on the AGE that is produced during the procedure, and therefore there's no evidence for its blanket use from what we could find. And there are also issues around informed consent for the patient just using this in a blanket method. Some patients are allergic to these materials, others aren't, but you need to be very careful that you actually inform the patient and get their consent if you are going to do it. It's not a case of do not do it, it's just there is insufficient evidence to show that there is any effect.
Thanks. I think that clears up the rationale behind our decision. It may well be that evidence comes forward in the future to suggest there is a benefit, but at the present time there doesn't seem to be. It is worthwhile highlighting around the consent issue is that there would seem to be no patient benefit to the patient using the mouth rinse. The benefit is to the operator or the dental nurse, and that might again be a challenge in terms of consenting a patient to something which is of little benefit to themselves. There will certainly be situations where you might use preoperative oral mouth rinses for other reasons, so it's worthwhile just saying that. Excellent, thank you. So we'll bring Roshni in. I think she's been off the hook. So we advised to avoid AGE procedures during risk levels 4 to 5. Could we give some clear guidance about procedures for risk level 3, as this is hopefully the next stage we need to prepare for? Roshni?
Sure. So that's a very good question. I think even at an alert level 3, the virus is still in general circulation, and social distancing or physical distancing measures are still in place. So before we carry out any routine treatment, an appropriate risk assessment needs to be undertaken. And if you decide that that is something you need to carry out, then the appropriate mitigation measures need to be in place, which would include the fallow period. But I think it's very, very important to remember that it's still important to follow national authority guidance. And there are certain legal and contractual obligations that some of us will need to have and make. So that also comes into that consideration. And locally, these measures might be different. So I think it's also very important to emphasise that as well.
Thanks, Roy. Did anyone else want to come in on that? Or you good? Okay, we've got lots of, we've got several questions, lots of questions coming in and not very much time. So I'm going to do a few sort of quick fire ones. So what guidance is there with regards to patient using spittoons? Diane, would you like to?
That was me. So the guidance basically is that, well, there's been no changes to HMT 0105. And so, as long as we're keeping up with the infection control following their guidance, then there should be no reasons why we shouldn't be able to use the spittoons. Because otherwise the alternative was the funnels, the old funnel thing. And we didn't think that was very appropriate. So yeah, so as long as they keep up with the HT 0105, then they should be fine.
Thank you. I'm not old enough to remember these funnels, as you can imagine. So,
no, neither am I, actually.
Neither are you obviously, because it's always good to end on a rude note. Right? So here's one. My practice does not have a separate area for donning and doffing PPE. What would you recommend? Roshni, you?
So we suggest that donning is carried out in a clean area, and suggesting that doffing is in the surgery retaining the mask. So I think it's important to carry out an appropriate assessment of the facilities to be able to ensure that that can be carried out.
Okay, a few off the Q&A here. One from John Hill. I appreciate at this moment in time, every patient we see now should be risk assessed, ideally. But for clarity, should we simply deploy the advanced PPE for everything? Onkar's looking like he's unmuted, so go for it.
Well, it's a hard one to answer. Again, really depends on the procedure you're carrying out, and obviously the individual risk to yourself, to your staff. You really do have to carry out a thorough risk assessment, and then that will actually lead you to decide on the most appropriate PPE you should be wearing. And I suppose if you're going to wear full PPE for every patient, that's purely up to you. But it's really got to be led by risk assessment. I mean, what do you think, Mick?
I would agree that it is down to a risk assessment, but we need to bear in mind that if we're carrying out a very low risk procedure at a low level, then there isn't a blanket excuse to just wear very high levels of PPE for every single procedure. And we need to bear in mind that these things are in short supply at this current time, and there is also a financial element to this. And whilst finances shouldn't come into it, they obviously do if we're going to do this for every single patient at low levels when they're unnecessary. We just need to risk assess what treatment we're doing, to whom, where we're doing it, in what situation, and recognise the national alert levels in which they're actually being done.
Okay, great. Right, we've actually passed the hour mark, but there's so many questions coming in. I've asked my mum and she said we can stay on for another 15 minutes. So here we go, quick fire. Should we be covering patients' hair when doing high-risk AGEs? Who's going to stick their hand up, or will I pick on someone? Onkar looks as if he's looking knowingly into the camera.
I didn't mean to look into the camera there. Right. Should we be... I suppose the guidance is for high-risk procedures, we should be gowned up. Well, should we be covering the patient's hair, was the question, was it?
No, our own hair. And I think that one of the reasons we went with this decision, I seem to remember, is it's in alignment with PHE.
Yes, that's right.
Yeah. So if you wanted that out, I think there were concerns raised within one of the work streams that the aerosol can actually contaminate hair. That's one of the first things you do after you've doffed and you've taken your mask off and you've gone out of the area. You run your hand through your hair or across your lack of hair, and so it's possible you contaminate yourself that way. But I think we went with the guidance that was currently from PHE. So while you're there, we'll carry the next question over. Is the use of thermometers. What's your view on that? We advocated that it wasn't appropriate to, or it was unnecessary, not inappropriate. It was unnecessary to use check temperature for all patients. Onkar?
So is that to me? Yes. Yes. I mean,
yes. Should we use temperature checks?
Well. First of all, it's the reliability of the infrared thermometers. Again, they're not as accurate as they can be. And secondly, temperature alone doesn't really give you as much information as you need. So, a patient may have a raised temperature, but that may be due to having, sort of a dental infection, which would raise it. So therefore, you may be turning patients away that actually need the treatment, and it may not actually indicate that that patient is COVID positive or suffering from the disease. So it's not really a reliable measure. I mean, it can be used to reinforce if you have other symptoms, but in itself, which is why I think that's exactly what we pointed out in the guidance.
Yeah, lovely. Okay. And we have Chet. Would you like to come in on that?
Yes, hi. I think I just want to add one more thing to what Onkar said, is that if you look at the rates of asymptomatic patients with COVID, if you look at some studies, that could be up to 60 to 70, 60%. So there's a lot of patients who won't have a temperature that could be COVID positive. And there could be some patients who've got a temperature who could be COVID negative. So I think the key thing is not to say don't do them, but actually look at why you're doing them. So say, look at the who needs a temperature check. And if you have a temperature, don't say, oh, this is COVID and send them away. See if there's a dental cause, because the worst thing that could happen is that you've got a diabetic patient on insulin that comes in with a dental abscess, who's basically got a temperature, who's turned away, and the next, a day later, they're on ITU with Ludwig. So I think you've just got to make sure that you do, I'm not saying don't do temperatures, but you do them not just as a standard, but actually targeted temperatures and targeted assessments, because the key thing is there'll be many, many, many patients who are asymptomatic that could still be COVID positive, and there'll be patients who have a temperature, but you've got to at least exclude other causes such as dental infections. So I think do them, but don't do them blankly and blanketly. Do them as a kind of a targeted, so you actually can make more sense of the results.
Okay, thanks, Chet. Couple more. Fallow time after a low risk AGE or a non-AGP. Mick?
Well, if there is no AGE, then there is no need for the fallow time. The fallow time is there to allow the aerosol to settle. So if you are not carrying out an AGP, then you do not need to have that fallow time.
Okay, so I think that's the view within the guidance is if it's a low risk exposure, you don't require a fallow time. Obviously, clearly, you are going to have your probably slightly extended cleaning time, although remember, we are applying universal precautions, but very much based on HTMO 105. It's perhaps Roshni might like to take this one. It said, can we do a permanent filling?
So I think, as I said earlier, it really is about taking an appropriate risk assessment for the need to carry out that treatment. And if you do need to undertake that treatment, you need to have the appropriate mitigation measures in place, and also reflecting the national alert level that's in place. So I think the guidance suggests that we need to really focus on those treatments that are perhaps urgent and essential at this stage, considering the national alert level in place at present.
Okay, and then another one while you're there is, can we use a slow speed handpiece?
So I think we were speaking about this within the task group as well, in terms of the slow speed handpiece and whether it's air driven or it's via an electric motor. So I think, again, if you need to be using a slow speed handpiece, we need to be making sure that we have carried out appropriate isolation to reduce the amount of aerosol that is being created as well.
And here's one, I'll throw it at Anka. Do you have any advice or guidance for clinical dental technicians regarding PPE treatment, taking into account the fact that no AGP are used, it says?
I think the guidance will be the same as the guidance we've applied in our document, and I think the conclusion we came to was that for prosthodontics, which is really not producing any aerosols, that it's a low risk procedure, and it can be carried out with obviously having carried out the risk assessment to make sure that everyone is safe, and if it's appropriate, to use normal level PPE.
Okay.
Yeah.
Thanks, Olga. I mean, I guess the point to stress on the question as well, just in addition to what Anka has said, is referring to no AGP, but the same principles apply that we've discussed this evening. Is it may well be, if you are treating a patient with a significant gag reflex or coughing or respiratory problems, you may not be creating an aerosol yourself, but you may be exposing yourself to splatter, to droplets. Which is clearly a significant risk. So you need to bear that in mind as well. I think we felt our document, it was beyond the scope of our document, but I guess there will be, much of it will be transferable over to CDTs. So if we jump back on track again, just for the last couple of questions, Roshni, there's so much guidance out there at the moment, including BDA, PHE, and many others. Which should we follow?
Really good question. Unfortunately, there is no one size fits all guidance. Each body has their own individual scope and they will deliver guidance in accordance with that organisation. I think often this guidance isn't conflicting, and it's important to stress that usually a consistent message is being delivered. It just may be presented differently. I think it's very, very important to remember that safety is at the core of all of these messages, and I think that's important to remember that when we are carrying out any patient care, that we keep that at the absolute crux of what we're doing.
Okay, thanks, Roshni. And another one that's come in from an eminent orthodontist, John Matchell, and he's asking, for orthodontics, is it acceptable to use 3-in-1 and slow speed handpiece without enhanced PPE? Who would like to answer that? Mick.
I think, I mean, 3-in-1, I can probably answer that. I've seen a few things pop up about 3-in-1. 3-in-1 is a tricky one, because if you use the 3-in-1 as a 3-in-1 with air and water at the same time, you will create an aerosol. And that will increase the risk throughout the whole procedure. If you use water on its own to irrigate, then you're not creating a great aerosol. If you use very low pressure air on its own, then you will not create an aerosol. If you use high pressure air and water at the same time, or high pressure air after you've just used water, you will create an aerosol. So you really need to think about what you're doing and where. There is no easy fix. You need to look at the procedure and look at how you're using the instruments that you have. Some areas have actually said don't use 3-in-1 at all. We're actually saying be sensible in its use and use them separately, do not use them together.
Yeah, thank you, Mick. And it is worthwhile highlighting, or just pointing out, that a number of the specialist societies have come up with particular advice around the procedures that you would carry out, and certainly there's some excellent resources on the BOS website, which I'm sure John is aware of. There's a question that's just come in, and it's a very short, interesting question. Do we refer AGP, so high risk AGE, to a UDC, so an urgent dental centre, at the moment? So if I go to my Welsh colleague first, and then we'll have an answer from one of our English colleagues.
Yeah, I mean, well, certainly within Wales, currently, absolutely yes. But that isn't doing routine dentistry. They are urgent treatments, and they should be treated for urgent treatments. We don't want to overwhelm these places. So urgent treatments, currently high-risk AGPs are carried out in the urgent dental centres.
Okay. And in Oncar in England?
Yeah, I think that is the same situation in England. So AGPs, when they're required, are for urgent care only and carried out in urgent care centres.
And then if I can ask a supplementary question, from the 8th of June in England, does the same apply?
Now, I don't know how to answer. I think routine care is still, I think for emergencies, we may be able to carry out AGPs if and when necessary in practice, as long as we have carried out a thorough risk assessment and we have the appropriate protocols and PPE in place. I mean, that's my understanding. Maybe you know.
No, fantastic. No, that's my understanding as well. And certainly, I think I saw briefly some advice come through on the southwest area from the area team, saying that we shouldn't open our practices on the 8th of June to see patients if we were unsure or uncertain that we had the adequate protection, the adequate protocols in place, and an appropriate SOP. So I think we need to be careful that we are continuing to protect ourselves, protecting our staff. And although the announcement is that dental practices will open on the 8th of June in England, that doesn't necessarily mean we throw the doors open and we start doing routine dentistry, which I think we're all aware of, but it is a message that we need to be getting out there. So we've run 15 minutes over, and I'm going to get into trouble if I stay up any later. So it just leaves me to thank all of you for hanging on in there and listening to us, and hopefully answering some of your questions. A big thank you to Mick, Roshni, Onkar, Chet, Diane, and all the guys behind the scenes who have helped arrange this and make it possible in an extremely short time frame. We also like to thank GSK, who have supported us in getting the webinar up and running. And as I said earlier, they're also going to be able to help us produce guidance that is maybe in a slightly more accessible format. I mentioned previously that to help get this guidance across to you and make sure that it's readable and it's practicable and that you're able to put it into place in your practices. We've done the webinar this evening. There are other webinars that are scheduled in the next couple of weeks through ProDental, who have invited us to do that. We're looking at having a resource on the College of General Dentistry website. So that's www.cgdent.uk. And I would urge you to go on there, register, and then you will get alerts and updates every time that the guidance is changed. We had to do that guidance and turn it around in 3 weeks. That would not have taken months, if not years, to do the guidance. So there are going to be errors or shortcomings or issues that will be highlighted by others, and we will be able to change it, and we'll be able to have a live document online. The other thing that we all hope is that there'll be additional guidance from Public Health England and SDCEP, and perhaps some research that comes through that we will react to, and we'll adopt that and implement it within our guidance. So it's just a huge thank you to all of you for listening. Big thank you to the task group in particular. And I wish everyone luck in the next few weeks and months. And I hope that we all get through this and we get through it together. So good night.
Bye.